Chapter 26, Hematologic and Renal Emergencies. This chapter is it's just kind of really more an informational chapter than anything. Most of the emergencies covered in these chapters, there's really not much at the basic level we can do for these people, but it is good to have a little base knowledge here so we can get a little understanding of maybe what's going on. And it does cover a couple of somewhat common conditions that we deal with, yet there's not a lot of emergency to some of these. So our objectives, of course, on page 601 in your text. A couple of multimedia videos for you to watch about sickle cell anemia, and then some information about renal failure. And our core concepts that we're going to cover is disorders of the hematologic system, or the blood, and disorders of the renal system, or really what's the urinary system. So hematology. Blood is its own organ system, although it works very much in conjunction with the cardiovascular system. It has a number of very specific functions that it performs. Really is more of a delivery system of both in and out. So it delivers the oxygen and removes the CO2, as well as moving nutrients and then other types of waste product from the organ, delivers nutrients to and takes the waste products away from the organ system. It has an indwelling capability of itself to do some clotting. So it has certain clotting mechanisms and clotting factors, of which I think most of us are familiar with, that it is responsible for. And it also is a means of maintaining the water system. And it works very much with the renal system to maintain water. So blood is made up of solid components, and those solid components are the first three: the red blood cells, the white blood cells, and the platelets. The last component there is not a solid organ, or not a solid component, but it is the liquid component that all the other elements or components are suspended in. So plasma is more like the soup of the whole thing. It's the broth in the soup, and plasma, if you want to take a moment and remember, is water with proteins in it. So it's a thicker broth than just plain water. The red blood cells, of course, are the ones that do most of the transport of nutrient and a lot of the waste. White blood cells, while a relatively small component of blood, does have a very important job in the hematologic system, as those are the ones that go out and attack the antibodies that make it into our system. Attacks the antigens that make it into our system. The platelets are the clotting mechanisms. So basically they're fragments of, in most cases, red blood cells that have been modified and have some chemical mediators on them that help them do their job of sticking together and plugging up any holes in the system. And then medications can affect some of these components. If you don't have enough iron in your system, then you get a more classic sense of anemia, and that lack of iron causes you to not have as good a hemoglobin, which causes some dysfunction in the red cells being able to transport oxygen like they should. White blood cells, certain conditions such as leukemias can make these skyrocket. Certain medications can also kill these all off, like chemotherapy can kill these off and make it much more difficult for them to fight infection. Platelets, there are a lot of patients who are prone to blood clots that end up on some sort of a medication to keep them from clotting so quickly. Coumadin would probably be our most widely known drug that does this, but aspirin to a certain extent does this, as does most of the NSAID drugs, which would be ibuprofen, which is commonly called Motrin, or the other common NSAID drug is naproxen, which is often called Aleve. Those can have some effects on your blood's ability to clot. Of course, if you get dehydrated, you decrease your plasma. So anemia is a lower than normal amount of red blood cells. Anemia, to an extent, can also be blood cells that are unable to appropriately function. And there's a couple of good examples of that. So we can have acute anemia, such as a sudden blood loss. So if you were involved in a major accident, maybe you bled out a couple units of blood, a couple liters of blood from your trauma, you would become acutely anemic. So your body would not be able to transport oxygen and other things like it should. Or you can have chronic anemia. Some females, I think it tends to really run more in the very petite, small females. Excessive menstrual periods can actually cause them to become slightly anemic over time. Slow GI bleeds. The body takes a certain amount of time to regenerate blood cells. It doesn't just make them overnight and dump them in. It can take several weeks for red blood cells to return to normal levels. And then diseases affecting the bone marrow. So like I mentioned before, people with leukemia will often have issues with appropriate levels of white cells. But you can also have people with that just don't make enough red cells. So sickle cell anemia, this is a genetic disease that affects the red blood cells. It's more prevalent in African Americans and in people of Middle Eastern descent. And it's a defective shape that makes the blood cell look like a sickle as opposed to the kind of modified donut shape. So if you look on page 604 in figure 26-2, they have a photograph here of some normal red cells and some sickle red cells. So you can see that the sickle cell is much different. It's longer, yet it doesn't have the full formation there in order for it to attach nutrients like it should. They also have a much shorter lifespan, which leads to anemia. So these things, while they're produced, often the body may think that they're doing okay, but then they die off much quicker and it's harder to replace. So some of those complications that go with sickle cell anemia, a destruction of the spleen. If you will take a moment and remember that the spleen really is your blood bank and then to a degree a blood filter. And this is like when you have an air filter and you run through the dirtiest, dustiest roads in America. Over a very short period of time, your air filter fills up with dirt in your car, so it makes it much more difficult for your car to pull air in like it needs to for appropriate combustion. Well, the same sort of thing happens here. You get these oddly shaped sickle cells, and they start getting stuck in the tines, and they start getting stuck in between the little folds, and they don't come out very easily. Whereas if you have those nice rounded red cells that normally people have, they just kind of bounce around. They don't get stuck. They don't get wedged into places quite as easily as these sickle cells do. They can have a sickle pain crisis in which all these cells start to kind of catch on themselves. So if we think about taking a handful of red blood cells, maybe putting them in a Yahtzee shaker cup, like we're going to roll some dice, and we shake them up and we dump them out on the table, they're just going to kind of scatter everywhere because there's no reason for them to stay together. They kind of bounce off. Whereas if we take a whole shaker cup full of sickle cells, shake it up, and we maybe dump them out, a lot of these sickle cells, their corners are going to catch on each other, and they may stay clumped together. Well, they can clump together like that in certain parts of the body. So oftentimes it ends up being in the extremities, but it can be in the spleen, like I mentioned, or it can be in other areas such as parts of their abdomen. it can cause them to have a priapism. Priapism only affects males. Priapism is a prolonged painful erection because of those red blood cells kind of stacking up, and they're affecting the drainage of blood out of the penis. So the penis can't drain the blood when it no longer needs it, and it just gets stuck, and all that blood just stagnates there. When you hear them talking about if you have an erection lasting longer than 4 hours, when we're talking about certain erectile dysfunction drugs, that's because they can lead to a priapism, and in some cases leads to requiring amputation of the penis in order to rectify the issue. Of course, stroke can potentially be a big issue as well. You get these things to clog up vessels in the brain, and all of a sudden the brain starts to starve. So treatment of the sickle cell anemia, high flow oxygen is generally recommended. You may not even get a really good accurate reading on your pulse oximeter because a lot of these cells don't have the capacity to carry the oxygen that we need to. So high flow oxygen is almost always appropriate for these people. Monitor for respiratory distress. They can develop these clots in their lungs, which is called a pulmonary embolus, if you remember. Monitor for signs of hypoperfusion. They can get some of the blood really trapped in certain areas and cuts it off from the general population. And then transport to a stroke center if you strongly suspect a stroke. So again, you're going to have to know what local protocol is for strokes. 1 in 12 African Americans have a sickle cell trait. Doesn't mean they always go into crisis. Doesn't always mean that they're going to have complications, but it means they have the potential for them to pass it on. And in a lot of cases, they will maybe live their whole life not even realizing that they carry the trait because it wasn't something that they fully developed the disease. So here's your video on sickle cell anemia. You can watch from the non-recorded PowerPoint. The renal side of things are components of our renal system. We have 2 kidneys, 2 ureters, 1 urethra. We also have a urinary bladder in there. But the kidneys, of course, do the filtering and creating of the urine. Ureters drain the urine from the kidneys into the urinary bladder. The urinary bladder holds the urine until it gets to a point in which it's becoming full and sends a signal to the body to drain. The body will then dispel the urine through the urethra, and that comes out through the external urethral meatus, which is either the single hole in the penis or one of the holes in between the vulva, just anterior to the vagina. It is responsible for filtering blood and removing waste. So it filters the blood, and it really does a great job of doing this, and it maintains fluid balance as well. So when the body says, too much fluid, let's dump some salt, because salt and water are best friends, you get rid of extra salt, you concentrate, you make very, very concentrated urine and dump some of that salt, and then some of the water starts to go with it. And vice versa, maybe your kidneys say, hey, we don't have enough salt or we don't have enough water in the body, we'll retain some of that salt. Salt makes the water stay behind. So it's very good. It's very efficient in the way it does that. And also maintains an acid-base balance. So when there are excessive amounts of certain waste products in the body dumps it, says let's get it out of here, and that will alter the acid-base setting, alter the pH, get rid of extra uric acid, or we maintain some of those acidic properties, try to move things back to a normal range. So renal failure occurs when the kidneys lose their ability to adequately filter and remove toxins. These can be acute from like shock or toxic ingestion, or they can be chronic renal failure. They can be inherited. They can be secondary damage from uncontrolled diabetes or hypertension, those being the 2 major causes of chronic renal failure. Some people with acute renal failure will have a small period of time in which they may be dependent on dialysis to help filter their blood, but in many cases bounce out of it fairly well. Some of them will then go on to chronic renal failure, and chronic renal failure in most cases is the beginnings of the end. However, how far out that end is a lot of times depends on the patient and how well they care for themselves. So there are a lot of patients that, well, I got this as a result of my uncontrolled diabetes. Why am I really going to start to give a crap now? And they're going to have a fairly short lifespan. But there are people who do very well for a number of years on dialysis and can live basically fairly normal lives before things get really bad. End-stage renal disease. This is an irreversible renal failure. It will require them to have dialysis, whether that's hemodialysis or peritoneal dialysis. And 90% of people get hemodialysis in a specialized dialysis center. People that are on peritoneal dialysis get dialysis just about every day and sometimes multiple times a day. It really kind of interrupts their daily life, but yet they can do it mostly at home. Requires them to have certain amounts of fluid basically pumped into their abdomen. So it washes, if you will. Let's think about if we stick a needle through your abdominal wall and we fill up all the space between your organs with fluid. And yeah, you're probably going to look like you're pregnant. And you fill it up with fluid, and that fluid has the right chemical balance in it that it draws out a lot of the toxins. And then after a while that you have sat with that in there and has drawn some of those toxins out, then you turn around and you drain all that fluid back out of there, and as it drains out, then it also pulls those toxins out. And people sometimes will do this, it'll be something that goes on all night while they sleep. People with hemodialysis, on the other hand, are the people with shunts that get put in or fistulas that get put into their body. And they'll go spend around 3 hours at a time hooked up to a machine 3 times a week in most cases. And the blood is pulled out of their body. It's run through basically an artificial kidney, if you will. We'll call it that. That's the dialyzer, the dialyzing machine. And if you've never seen a dialysis machine, they're fairly large machines. They are, probably about 3.5 to 4 foot tall, maybe 2 feet deep, and about 3 feet wide, 2 to 3 feet wide. They're fairly large. They're like they're bigger than a dorm fridge, but not quite the size of a full-size refrigerator. They're getting smaller, but still a pretty monstrous-sized machine. And this will take the blood out, and it runs it through a series of filters and exposes it to a series of chemicals and electrolytes, and in the process pulls a lot of those toxins out. Again, it takes around 3 hours, and usually it's about 3 times a week. More than 350,000 people in America receive some sort of treatment for end-stage renal disease on a yearly basis, and only 8% treat themselves at home. And many of these end-stage renal disease rely on us for transport to and from dialysis. Now, in most cases, early on and when the patient is doing fairly well and is fairly stable, they can either transport themselves, or they'll go, say, in a wheelchair van or some sort of a public transportation. It gets to a point, though, in which they may then start having to call the ambulance to transport them back and forth because they're too weak to stand up or sit or something along those lines. More and more, dialysis used to be exclusively done in hospitals, and then more and more these days we're seeing it done in a lot of outpatient settings. Hospitals still do dialysis, and when people are really sick, they'll go to these hospitals that are capable of performing that. But the majority of people aren't going to spend the remainder of their life in the hospital. So that's when we start to get involved. And sometimes we're even called to the dialysis centers for people who get sick at the dialysis center and need to go to the emergency department. So this shows you a couple types of catheters or fistulas or ports. Often they're called ports, but it's really a fistula or a shunt. The two types that you see here, you see that the gentleman on the left with the 2-port catheter, he's got a red one and a blue one. One is to take the fluid out, and the other is to take the blood out, and the other is to pump the blood back in. With the fistula, AV fistula on the right, they have gone in and created an artificial connection between a large vein and a large artery. And that connection, they will plug a couple of needles in to pull the blood out and put the blood back in. They've kind of built it up so it's a little more ready, a little more sturdy to constantly have needles poked in and out of it. If you have a patient that has an AV fistula in particular, the 2-port catheter should be somewhat of a concern, but really more is the fistula. Do not take a blood pressure on that arm if you can avoid it. If you absolutely must take a blood pressure, try to do it on the lower arm. Try to do it on the forearm below that fistula, and you may just have to palpate it. Remember, you can take a blood pressure in the leg. In fact, I did that just over the weekend. I took a blood pressure in a patient's leg because they just had a double mastectomy. She had had both of her breasts removed within 48 hours prior to calling an ambulance, and we were not able to put a blood pressure cuff on her arm because of the trauma that she had undergone, as well as the potential for the lymph nodes to be removed as well. So if you're going to use the leg, remember, it's a blood pressure cuff around the leg. Put the bladder part, the part that expands, on the back side of the leg, and put your stethoscope head right in the soft part behind the knee, which is called the popliteal area. And you can get just as good of a blood pressure there as you can in the arms, and it may even be easier to hear. So these are definitely not something to mess with. Paramedics will not start IVs in those arms if at all possible. Once in a while, it's worst case scenario, but that's how they access the blood for the circulation. Here's an example of peritoneal dialysis attachment point. Really, it's their shunt, or more or less, and this uses the peritoneal cavity's large surface area, and it infuses this dialysate, is what it's called, dialysate. Infuses it into the abdomen, leaves it there for a couple of hours, pulls out the waste, and then it's removed and discarded. So medical emergencies for end-stage renal disease, 2 broad groups: loss of kidney function and complication of dialysis. Most dialysis patients have underlying medical factors: diabetes, hypertension, cardiac disease, lung disease. Many of these people have issues with this. So when we're talking loss of kidney function, in most cases we're called to that on days in between dialysis, because the day that they get dialysis, their body's actually fairly stable in the sense of waste products and in the sense of fluid balance. A lot of people with end-stage renal disease make really no urine. There's people who do not go to the bathroom to urinate because they make absolutely none. And so they have a difficult time getting rid of a lot of their extra fluid. So they're on a fluid restriction. So you might have a patient with a heart problem and they have end-stage renal disease. They can very easily go into congestive heart failure because there's just too much fluid left in their system. But like I said, a lot of times it'll be the further away from their last dialysis they are, that's when you would more than likely see some sort of an issue related to that, either waste buildup or fluid buildup. Complications of dialysis, on the other hand, they can build up blood clots. They can have excessive bleeding, which would be completely the other side of the coin. They may have taken too much fluid off, and now the patient is hypovolemic and turn hypotensive and in shock. So those are some potential issues. Sometimes the patient has missed their dialysis appointment, and that can create a major issue. Remember, these people are used to going 2 to 3 days at a time in between dialysis. If they miss an appointment because they were sick or couldn't make it or something, and they can't get to dialysis again for another 2 more days, this person has the potential for serious illness, if not death. So people with these sorts of issues are going to look like congestive heart failure patients, and probably are in a certain extent congestive heart failure patients. They're short of breath, they have edema, they have electrolyte disturbances, which is really the same thing. The problem, though, is they have too much fluid for the heart to actually handle, where in most congestive heart failure patients, the heart is just not capable of handling the normal amount of fluid, but it really looks almost the same. So if they've missed their dialysis, obviously our same basic assessment techniques: be aware of their fistulas, try to avoid them, take a look at them, see if they look like they're infected. And remember, they will be a little red and maybe possibly a little swollen. That's kind of normal. But ask the patient, how does your fistula look? Does it look like it's normal? Is it hot? Does it have a fever? Do you have a fever in general? Administer oxygen. Remember, we're going to usually base that off of our pulse oximetry and protocol. But if they have excessive amounts of toxins in the system, oxygen can be very helpful in counterbalancing. Monitor their vitals closely. Have your AED ready. It's not uncommon for renal failure patients to have an arrest. And then transport to a facility capable of dialysis. Most of your larger city hospitals have dialysis as a capability. The Med Center, which primarily the Clarkson side of the Nebraska Med Center, and Creighton both have fairly big kidney programs, but most of the other hospitals also have the capabilities to do a quick dialysis if necessary. But you would need to look at what your local protocols are. Complications from dialysis: bleeding or clotting and infection tend to be the biggest issues that run there. You can get a peritonitis as well. Peritonitis is not as likely from the hemodialysis patient as it is from the peritoneal dialysis patient, because when you're filling the abdominal cavity with certain types of fluid, if you didn't keep things very clean and sterile and sanitary, you can introduce bacteria into the abdomen. So if we're going to treat these complications, control any bleeding, contact medical control as necessary. You may need to be pressing direct pressure on that fistula the entire time you have the patient. O2 and treat for shock. Keep them warm. Put them in a supine position. Raise their legs as necessary. Now, if they have a difficulty breathing, that can be a slippery slope. You may not want to raise their legs. You may have to keep their head slightly elevated. And if you have a suspected peritonitis, transport the dialysis fluid for confirmation. If they have a sample of the bag that has emptied their peritoneal dialysis or their diacylate, take it along, and the lab can do a test on it and see if there's any toxins or any foreign material in it that can attribute to this infection. Kidney transplants. Kidneys are the most transplanted organ. Approximately 16,000 transplants each year for kidneys. And patients will spend their lives on specialized medication. Once you've had a transplant of a significant organ, you're going to be on an anti-rejection drug. Basically, they trick your body into reducing its defenses in order to maintain that organ. Otherwise, they reject it. So these medications will help them reduce their body's response to this foreign material, but it also makes them more susceptible to infection. So that's a big potential trade-off there. So these people have to be extra cautious and very, very attentive to their own bodies and knowing if they're having an issue or not. They're starting to get sick. So there's a little information about renal failure. So very quickly, the chapter review: blood consists of those various types of cells, white cells, red cells, and platelets, as well as plasma. Anemia is a lack of red cells or red cells that can do the job in the circulation. Sickle cell anemia is an inherited disease in which the defect of the hemoglobin results in the sickle shape of the blood cell. This misshaping inhibits its appropriate movement and doesn't make it nearly as efficient what it does, causes a sludging and a blockage and smaller blood vessels can lead to some serious complications. The renal system is composed of the kidneys, ureters, urethra, and urinary bladder. The kidneys create the urine, ureters and urethra drain it, the bladder holds it. Kidneys perform a vital filtering function to remove that waste and help maintain water balance. Problems with the renal system can include things like infection, kidney stones, renal failure. Renal failure is a condition in which the kidneys are unable to filter the appropriate waste and maybe do not create any waste or urine. And in dialysis, this is a method of removing excess fluid and toxins from the body. It can either be via hemodialysis or peritoneal dialysis. People who get dialysis generally go 3 times a week for several hours at a time. The main complication with patients in end-stage renal disease can occur if they have missed a dialysis appointment. So blood has specific cellular components. Abnormal blood cells can significantly affect patients. The renal system is critical to maintaining homeostasis. Renal failure can be chronic or acute and can be managed through dialysis. So questions for you to consider. Does my patient have a history of sickle cell disease or end-stage renal disease? Does my patient have an AV fistula? And will I need to make an early request for ALS because of complications from a missed dialysis appointment? The answer actually to that one is rarely will you need to do that unless the patient has other life threats. The paramedics cannot do dialysis in the truck, so outside of taking care of the supportive things of the airway, breathing, circulation, and occasionally pain control, ALS probably won't make a huge difference here. So if it's something that you can get them to a dialysis center or a hospital capable of dialyzing them, that's probably your best bet. We have a patient who's transported routinely for dialysis 3 times per week. She was sick and canceled her trip yesterday. She now calls saying she can't breathe and feels like she's going to die. Is it possible that she has a legitimate complaint after missing dialysis by only 1 day? It is. It is very possible that she could have a legitimate complaint after only 1 day. She may have been not as good, and when I say good, I mean not as diligent in watching her fluid intake and her salty foods and whatnot. And she may have already been kind of in overload. She may have been sick yesterday from being kind of in overload. By missing dialysis, she just compounded the problem. For this patient, if she's complaining of shortness of breath and feeling like she's going to die, this is a case in which ALS is probably very appropriate. She's probably not going directly to dialysis today. Rather, she's going to the emergency room. They're going to look at some potential issues with her breathing, try to stabilize that, and then possibly get her dialyzed there shortly after she's being discharged from the emergency room.